Dr. Diaz, where are you from?
Born and raised in New York City, and then I moved out here for college. Went to Loyola Marymount, and then I left the States and went and did medical school in Ireland. Met my husband, came back to do my training here in the U.S. I went and did my neurology residency at Northwestern in Chicago, and then back here to LA, where my family had finally settled, and finished the last bit of my training at UCLA, and that's where I've stayed.
Awesome. And how did you decide that you wanted to go into movement disorders?
Yeah, so I was in my neurology training at Northwestern, and at that point, I was thinking I might go into stroke. I kind of liked everything I had learned about stroke, and I was thinking about doing some electives and going down that route. And as I've said many times, a lot in life happens because of people that you meet and the mentors and teachers that you have. And so it was a very competitive time to do stroke. I couldn't get the elective that I wanted, so I ended up doing an elective with somebody at our university that does movement disorders. She happened to be the director of the residency program at the time. And spent a month with her, and she was a great teacher, and I just found it fascinating, the kind of the patients that I came across, the power of, watching somebody even before you sit down and have your appointment with them. You see how they walk in from the elevator, you watch how they're moving, you listen to how they're talking, how they're interacting with other people. And many times we can almost make the diagnosis before we've even examined them, just by listening and looking at some of those things, listening to the symptoms that they've had. And so I fell in love with that part of neurology, that it's, so conceptual and watching and observational, and the conditions that I treat, they're chronic conditions, and I love that I, long term, I get to establish a relationship with these patients, get to know them, get to know their families, do a lot of counseling. And so, it was that first elective that I did with this one mentor that really just solidified it for me, that this is what I wanted to do.
Very cool. And how does the diagnosis typically happen? What can a patient expect?
So, a lot of neurology and movement disorders is really specific in this. These are mainly clinical disorders, a lot of them, meaning that we don't have one test that definitively gives you a diagnosis. It's a combination of, gathering all their medical history. What are the symptoms they've had? How have they started? How have they progressed over time? And our examination, looking for certain things, and that gives us a suspicion of what we think is happening. And then we'll use other tools like MRI or other imaging or other tests to kind of help us hone it down. But it's a very clinical diagnosis in the sense that it's a process, going through the exam, the history, and then using testing to help us hone it in. I'm a specialist. I'm a movement disorder specialist. So sometimes when people come to see me, I'm not the first neurologist that they've seen. Occasionally it is, but sometimes these conditions are hard to diagnose, or sometimes they're hard for people to accept. So people might see, more than one neurologist. And so, for me, I'm trying to gather all this information, and sometimes, we don't come to the diagnosis on the first visit, but it's, come and meet, let's get to know each other, let's collect all the information that we have, and then, go through this process.
Right. And what are the most common diagnoses that you typically see?
By far, it's going to be Parkinson's disease. That's what the bulk of our clinics are, is Parkinson's disease. And it is actually something that we're diagnosing more and more these days. Then there's a variety of conditions that are similar to Parkinson's or under the umbrella of Parkinson's, but are different than Parkinson's, how they progress, how we treat them. Tremor, essential tremor and different tremor disorders, and they can sometimes be confused with Parkinson's disease. And then I see a variety of other types of conditions that have to do with movement, motor control, how the body, walking issues, limb mobility issues, dystonia, where people get sort of stuck in postures. And then I do a type of therapy that's called Botox therapy. So if people have had like a stroke and they have an immobile, stiff arm, I help loosen their limbs to help them move a little bit more freely.
And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/foundation.
So what kind of treatments exist for Parkinson's?
Most of them are oral medications, and we don't unfortunately have a cure for Parkinson's yet. But we have an arsenal of medications that we have available to treat Parkinson's, and it's a very individual condition. So, not everybody's going to be on the same medication when we start. It progresses differently in different people. So we have, a whole array of medications to choose from these days. I think last time I checked, we have more than 20 different medications available for Parkinson's disease. But, we take a lot into account a patient's age, what symptoms they're having, at what stage of the condition they are, and what potential side effects they could have from these to decide where we're going to go with medications. There's surgical therapy, something that we call deep brain stimulation, that's also available. It's not a therapy that is a good choice for everybody, so it's important to work with a movement disorder specialist or a neurologist that really understands it to understand who is a good candidate for deep brain stimulation. And then, of course, we use other specialists like physical therapists, occupational therapists, speech therapists, because it's very important to have these therapies that really help people exercise, how to use their muscles more effectively, how to use their speech more effectively. The patients have to do their part as well, which means exercise is very important, not only Parkinson's, but a lot of these conditions. We've learned over the last decade that regular exercise, staying active, is so good for the brain, not only for mobility, but memory, stress levels, sleep, all those sort of things are very important, for our general well-being, and regular exercise helps us regulate those.
Would you say that a patient would be able to live an active, healthy, happy life after a diagnosis?
That's what we strive for. My goal is to try to find ways to treat patients so they can keep doing what they want to do. Most of the conditions that I deal with are progressive conditions, but most of them are a slow progression over years. And so our goal is to try to pick and choose therapies that allow them to move and do the things they want to do. Don't bog them down with side effects. But our goal is to try to keep people doing, hobbies and work and enjoying family life as long as they can.
Nice. And what would you say to a patient who might be hesitant or nervous about a diagnosis?
Yeah, we get that a lot. People sometimes don't go see their doctors because of fear of what they might find or fear of what they might do, or, and I get it. There's this fear of the unknown, or what's going to happen to me, or what's going to happen to my family. I get it. The problem is, a lot of these conditions are treatable. Like, we have good medications, and sometimes, people wait until things are so bad that then it's hard to kind of backtrack and start things when people are already at that point of a lot of disability or immobility. And always, it's good for people to find doctors they feel comfortable with, that they can have open communication with, and realize that we're never going to, force anything on anybody. It's really good to just go get the information, have a conversation, what are the options that you have? What do you have? What are the options that you have? And then make informed decisions. And that's very important, because sometimes people are out there and they're suffering needlessly when we can do something about it and keep them on the road to like enjoying their life.
Right, right. Anything else that you would like people to know about your work?
Yeah, I mean, I think, like I mentioned, I deal with conditions that are long term, and sometimes I make the initial diagnosis, but I think a lot of the time people come to me after they've, kind of gone a couple of places and they really need a home. And I try to make this a very holistic sort of relationship where they get to know me. I think it's very important that they feel like they can communicate with me freely. I get to know them, and I always hope that people bring family with them so that there's a conversation going, because these conditions affect the family as well. They don't only affect the patient, they affect the spouse, they could affect kids. So it's always important for everybody to be on the same page and realize that we don't treat the condition. We're not treating Parkinson's when somebody comes to see me. I'm treating the person and the condition that they have. So we look at things from their perspective and what's going to work for them, and not just generally kind of go down the book of what the treatment for Parkinson's is.
Beautiful. Thank you, Dr. Diaz.
Yeah.